Okay, so good evening everyone. We are going to have a session of MIQ surgery where I'll be discussing 20 questions with you. Some questions have already been asked earlier, PYQ, some are new questions. And rather than discussing only the questions, I would like to tell you the whole topic. I mean, I'll tell you all the salient features of that particular topic. So, this question was asked last year in NEET also. It's a common question. I'm sure all of you know the answer of this. This question says, not included in the primary survey of triage is. So, I'm pretty sure all of you can answer. Primary survey only has A, B, C, D, E. A is airway, B is breathing, C is circulation and hemorrhage, D is disability, and E is exposure. C, CT is not included in primary survey. So, see, first thing that you need to know about trauma, and I'm sure all of you know, is the color coding of triage. Red, which is immediate, yellow, urgent, green, ambulatory, and black is moribund, where we only go for expectant therapy. So, this very frequently they ask, and what injury comes in this? So CT is not a primary survey, CT can be a adjunct. So, because adjunct is not the option here, only primary survey it says, so I'll not keep a CT here. And CT comes in secondary survey. So, in primary survey, these are the 5 things you do. And warfare injuries, we keep external bleeding, we give first priority, only warfare injury. So, in primary survey, these are the things you have to do in airway. What you do in airway, first of all, I want to remember the photo. They give you photo, and what you are doing actually, you are simply trying to reposition the airway, prevent the tongue fall, and maintain the patency of airway. So, one hand on the head, one hand on the chin, you try to pull the chin upward. This is called chin lift and jaw thrust, and this is the jaw thrust. Put your finger below the angle of mandible and try to pull it forward. So, another question was, which of the following is not included in airway, maintenance? One option was neck tilt. So, remember, neck tilt is not done. Neck tilt should never be done. That's contraindicated because that can cause cervical, spine injury. Second thing, if you are intubating, do an inline intubation. Don't extend the neck. Don't extend inline. The assistant will hold the neck, will keep it straight, and then you intubate. And before you do anything, if you suspect spine injury, always apply cervical collar. So, cervical collar or cervical stabilization should be done before you intubate if you suspect spine injury. Now, these are the important points to remember. First of all, the photo, head tilt, chin lift in airway and jaw thrust that you do initially. Neck tilt should never be done, and do cervical stabilization. These are the Gudel's oropharyngeal airway, that's the next step, you can put it inside. And in breathing, you manage pneumothorax, hemothorax, tracheobronchial injury, and cardiac tamponade. In circulation, you have to stop the bleeding to IV line. Color coding of IV line, you must know 16 is grey, 18 is green. And 1 liter fluid we give immediately in children 20 ml per kg, and tranexamic 1 gram should be given stacked. So, this comes in circulation. No, cervical stability is not a part of primary survey. It is a prophylactic measure to avoid cervical spine injury. So, it's not, doesn't come in primary survey. Before intubation, you should stabilize the cervix and exposure like log roll. So, I'll leave this part and let's come to question number 2. You all know this, there's nothing special here. How much fluid? No, head tilt is done. Neck tilt is not done. Manoj, head tilt is a part of this. Neck tilt is not done. How much fluid should be given to a 70 kg man? 30% burn in 12 hours. देखो, एक तो आपको पता होना चाहिए पार्कलैंड फॉर्मूला. दूसरा, you know ATLS guideline. And Muir and Barclay is not important, but I'll tell you what it is. So, Parkland, is 4 ml per kg per % of burn, and first 50% you give in 8 hours, next 50% you give in 16 hours, and the fluid of choice is ringalactate. ATLS is 2 ml per kg per percent of burn in adult, 3 ml in children and 4 ml in electrical burn. So this is Parkland. What on Moore and Barclay? Moore and Barclay is 0.5 ml per kg per percent of burn, and the fluid you give is human albumin, which is a question of INICT. So here 70 into 30 into 0.5. So first 4 hours I'll give 1050, second 4 hour I'll give 1050, third 4 hour I'll give 1050. So 4 hours you give, so initial 12 hours will be 3150. So this ETLS you need to know 2 ml per kg, in children 3 ml and in electric burn 4 ml. Parkland you already know. Galveston only remember the formula, you don't have to calculate it. Moore and Barclay, this is 1 unit, 4, 4, 4, 6, 6, 12. First 4 hour you give, next 4 hour, next, and then 6 and 6 hour and then 12. This is for 36 hour. And this is the question, what fluid you give? Human albumin. Evans and Brooks are not discussed, not needed. Not included in damage control surgery: decontamination, hemorrhage control, resuscitation, vascular anastomosis. What you don't do in damage control? So can you answer this question? It's a simple question, I'm sure you know. Yeah. In damage control, we don't do vascular anastomosis. The concept of damage control is there are 4 phases here. In phase 0, we have resuscitation. In phase 1, we do damage control, in which only control hemorrhage, control infection and stabilize the patient in terms of physiology. No further injury, this is you do. Definitive repair is not done in damage control. Keep the abdomen open, called laparostomy. Shift the patient to ICU for the management of lethal triad. And what is lethal triad? Lethal triad is acidosis, hypothermia and coagulopathy. You manage that. And again you bring back the patient to OT within 24 to 48 hours. Then you do definitive repair. That's actually phase 3. So damage control, this is the phase 0, resuscitation. This is phase 1 where you do abbreviated laparotomy, which includes hemorrhage control, infection control and no further injury. This is phase 2 in ICU where you manage lethal triad, acidosis, hypothermia and coagulopathy, and finally phase 3 where you go for definitive repair. Vascular anastomosis etc. done in phase 3. There could be a phase 4 also for complications like incision, hernia etc. So in phase 1 your aim is only abbreviated laparotomy where you control hemorrhage, control infection, prevent hypothermia and restore the physiology, prevent further injury. And this is the lethal triad: coagulopathy, acidosis and hypothermia. Well, so in labor you can do push, pack, Pringle and plug. This is Pringle's maneuver, which I assume you know. Abdomen is closed in phase 3. In phase 1 you keep the abdomen open, called laparostomy. Pringle is ligating the free edge of lesser omentum, clamping the free edge, not ligating, clamping the free edge with a vascular clamp. So you clamp the portal and hepatic artery and stop the liver bleeding. Hepatic vein bleeding cannot be stopped by Pringle maneuver. All this is a common question, I'm sure you know all this. So, and this is how you do. You can put a Bagota bag, you can apply towel clip, you can apply a sponge, do anything, don't close the abdomen. This is called laparostomy. This is what you do in phase 1. And then in phase 3, you close the abdomen. Right? Understood? This is Pringles. So, phase 0, patient selection, restriction. Phase 1, abbreviated laparotomy, control hemorrhage, control infection, etc. packing. Phase 2, ICU, lethal triad management, and phase 3, definitive repair. Now, yeah, phase 4 basically is late complication surgery. Anshita, we have three options for vascular injury. One is, if it's not an end artery, we can simply ligate it, just ligate it. Number two, you can put a stent inside temporarily to maintain the blood flow for 24 hours. Don't repair, like intestinal perforation. Don't repair, do ileostomy or simply clamp and leave in the abdomen so that prevent contamination. Repair I'll do in like third stage. Yeah, so here a very simple concept. Hypotension cannot be caused by head injury because cranium does not have so much amount of space to accumulate 3 liters of blood and cause hypotension. Blood loss in head injury, we have hypertension, bradycardia, Cushing reflex. So if there is a hypotension with head injury and no external bleeding, it's inside, it has to be in the abdomen or thorax. So intra-abdominal bleed is what you get here. So in head injury, what we need to know? We need to know CPP, cerebral perfusion pressure, is the most important indicator of prognosis. You have to keep it around 70. Mean arterial pressure is the pressure from below, ICT is pressure from above. So this should be high, this should be low, so that we keep CPP high. Mean arterial pressure, in the process of keeping it high, we have Cushing reflex, hypertension, bradycardia, and ICT we can bring it down. If it is more than 20, that's an indication for cerebral dehydrant like mannitol. So in head injury, what is your aim? Our aim is to keep the mean arterial pressure high and ICT low. And in the process of keeping mean arterial pressure high, we have hypertension. So what is Cushing reflex? Hypertension, bradycardia. This is triad, where is irregular respiration. So these three is called Cushing triad. Only these two are called Cushing reflex. And the reason for hypertension, as we have understood, the nature, why it does this? To keep the mean arterial pressure high so that we have high CCP. GCS is another thing in head injury. I am sure Dr. Gaurav also discussed this. ये रट लेना, ये खूब पूछा जाता है. Yes, we can give Anshita hypertonic saline. लेकिन hypertonic saline is given when the sodium is less than 145 and osmolarity less than 320. Normal osmolarity is 280 to 300. But when you give hypertonic saline, you are giving sodium, you are increasing the osmolarity. So if the osmolarity crosses 315 and sodium crosses 145, you should be cautious or stop this. So this GCS, I am sure you know, ये आपको रट लेना है, याद कर लेना. What are the features of external hematoma? Young age, fracture very common, bleeding is middle meningeal artery, rarely sinuses vein, 95% middle meningeal artery, lucid interval found. Prognosis is excellent if it's treated early, may cross midline but not suture line. So these are the features, and this is the CT finding, which I am sure very common finding. All of you must be aware of this. Subdural hematoma features are old age, occurs more commonly by bridging vein. So here the bleeding is venous, in external bleeding is arterial. Bilateral more common, and can cross suture line but not midline, and this is the CT finding, concavo-convex. If it is white, it is acute. If it is black, it is chronic. So this is chronic subdural because this is black, and this is acute subdural because this is white, and they are concavo-convex, while extradural is biconvex. There is no term like chronic extradural. Either patient will die or you operate, but subdural can be chronic and become black. So these are some simple points of a head injury, which I again presume all of you know this. This is acute extradural, acute subdural, and chronic. Chronic and acute will differentiate by color, white and black. If there is no eye-opening verbal or motor response, this will be 3. E1, V1, M1 is 3. Okay. A 25-year-old patient was brought to emergency with history of trauma. On examination, there is severe dyspnea, feeble pulse, blood pressure is 90/60, neck veins are engorged, absent breath sound on the left side, and shift of apex towards right. X-ray picture given below. X-ray picture unfortunately is missing here, I am sorry. But by history itself, you can diagnose. it is tension pneumothorax. What should we do? A 14G needle, the length should be 3.25 inches. That's the ATLS guideline. Insert the needle in the 5th intercostal space in mid-axillary line. This we choose for children and this we use for adults. Engorged neck vein, hypotension, mediastinal shift, this all suggests tension pneumothorax. So, deadly dozen you have to know in chest trauma. Tracheal obstruction, tension pneumothorax, open pneumothorax, massive pneumothorax, cardiac tamponade and flail chest, and aortic transection, tracheobronchial injury, myocardial contusion, diaphragmatic injury, ischial injury, they come in. This is called lethal 6 and this is called hidden 6. They come under deadly dozen, which you need to know. एक चीज तो confusion है, देखो. New ATLS guideline has done what? They have placed this tracheobronchial injury here and flail chest here, causing confusion. But no, you follow this protocol only. Forget the new ATLS, because in India we don't treat tracheobronchial injury in primary survey. In America they do. For them it's okay. For us this is the standard protocol. So this is the closed pneumothorax where the chest wall is closed, treated by ICD. Yeah, flail chest is included in lethal 6. This is the open pneumothorax. And this is open, the air comes from outside, and this is tension pneumothorax where the pressure is so high that the heart gets compressed, the vena cava gets compressed, and it can even cause obstructive shock, and it can cause many more problems. This I'll leave. Mediastinal shift to other side and dyspnea, and you all know this heart rate. ICD triangle is pectoralis major, descending dorsi, and nipple line, and the needle should be 14G, 3.25 inch. In children, this is what you prefer. In adult, this is what we prefer. Okay? And chest tube size also, it has been reduced. Earlier, we were using 32 to 36 French. Now we are using 28 to, ATLS has reduced the size of the chest tube, 28 to 32 French. This is the ICD bag, where the tube should always be below water. We call it underwater seal. Unlike Eurobag, where here you can see the tube reaches up to the base of the bag with a water line, while in Eurobag, the tube will end here and there is no water line. You can differentiate between the two. So, whenever the tube is going up to the base of the bag and there is a water line, this is ICD bag. So, always it should be kept underwater seal to prevent water entry, air entry during inspiration. If I don't keep it underwater seal, then we convert closed pneumothorax into open pneumothorax. Trophic ulcer are caused by all except. You'll get this file, So, can you answer this question? Trophic ulcer are caused by all except. Yeah, obviously this is very obvious, this is not a good question, but this is a PYQ, which is why I have kept here. Trophic ulcer are kind of pressure ulcer or neurogenic ulcer. Varicose vein will cause varicose ulcer, venous ulcer, not trophic ulcer. So, this is a classical picture of trophic ulcer, usually on the pressure point, like malleolus or like this heel or here or bed sore, and the edges will be kind of scarred and atrophic with dilation tissue at the base. This is classical trophic ulcer picture. Seen in neurogenic cause or pressure cause, syringomyelia, bed sore, they all are trophic ulcer. How to differentiate trophic ulcer from, no, gatorrhea will be venous ulcer. How to differentiate trophic ulcer from arterial ulcer? Arterial will be at the tip and you have ischemia, poor blood supply, atrophic skin, fall of hair, thin shiny skin, poor pulsation. So, ischemic ulcer are painful, you have other features of arterial insufficiency, while trophic ulcer are painless and no arterial ulcer. And this is a venous ulcer on the malleolus. See here, whenever you have pigmentation and or varicose vein, at the malleolus, these are venous ulcer, and this is the gator, area. So, venous ulcer getting gator area with skin changes of the venous ulcer. Like you see pigmentation, lipodermatosclerosis here. So these are the sites for venous ulcer. Arterial at the tip and at the pressure point, trophic ulcer. A 3-year child is brought to the pediatrician for the evaluation of lateral neck mass. On examination, a painless soft fluctuant mass is found on the lateral side of the neck as shown in the image. What is the most likely diagnosis? 3 things. First of all, this is a child. Number 2, I will give you a hint, posterior triangle. So, what do you think is the answer here? Of course, this is cystic hygroma. So, देखो 3-4 swelling you need to know in this neck. One is cystic hygroma, second is branchial cyst, third is Thyroglossal cyst, and fourth is rarely asked carotid body tumor. So, this is a cystic hygroma. What are the features? Number 1, obliterated lymphatic, usually found in the posterior triangle, due to lymphatic. Number 2, higher risk in Turner Down syndrome. Number 2, brilliantly transilluminate, and may cause obstructed labor or respiratory distress. Surgical excision is the main treatment, but you can go for stressing agent, which is OK432, picibanil, and these are the swelling which are brilliantly transilluminate. Vaginal hydrocele, epididymal cyst, cystic hygroma, ranula, and meningocele. And this is an image of brilliantly transilluminant swelling, where in the dark room you put light and you see they glow. This is the ganglion, see the hand ganglion, and this is the posterior triangle swelling. Ranula, epididymal cyst, ganglion, they all are. Don't just say many swelling are transparent, they are brilliantly transparent, that's the word. And another next swelling, branchial cyst, they are found at the anterior border of sternocleidomastoid, usually at the junction of upper 1/3 and middle 1/3, and they are found in adults, young age, second, third decade, and cystic hygroma you find in children, maybe neonate. So, remnant of second branchial cleft, older children, adults in, anterior border of upper and middle 1/3, lined by squamous, and treatment is surgery. Turbid, fluid is turbid because they contain cholesterol crystals. And what about branchial fistula? They are usually present at the lower part of anterior border sternocleidomastoid, and they pass through 9th and 12th cranial nerve. And this is the question they ask: what is the internal opening? Posterior tonsillar pillar. They open here, posterior tonsillar pillar, and open at the lower part of anterior border of sternocleidomastoid. Which structure is saved in radical neck dissection? Which structure is saved in radical neck dissection? Yes. We don't have to remove the vagus. We remove level 1 to level 5 nodes. We remove sternocleidomastoid, internal jugular vein, and spinal axis nerve. This is what we remove. If we preserve any one of them, then this is called modified neck dissection. Modified neck dissection. So, in radical neck dissection, we remove level 1 to 5, internal jugular vein, spinal axis nerve, and spinal. So, if I remove preserved nerve, this is 1. If I preserve vein, 2, and sternocleidomastoid 3. While in modified neck dissection, radical you remove all. In modified, you either preserve any one of them. And these are the level of lymph node which you need to know. Level 1 is submental, submandibular. 2, 3, 4 are jugular, upper, middle, lower. 5 is posterior triangle. 6 is central. 7 is mediastinal. We don't remove 6 and 7. We only remove 1 to 5. And these are the different variation of modified neck dissection. 1 submental, submandibular, 2, 3, 4 jugular, upper, middle, lower, 5 posterior triangle, 6 let's forget. So only 2, 3, 4 if I remove, this is called lateral. And if I go posteriorly 2, 3, 4, 5, we call it posterolateral. If I come anteriorly 2, 3, 4 and 1, we call it anterolateral. So with lateral is 2, 3, 4. Go posteriorly, include 5, becomes posterolateral. Come anteriorly, include 1, become anterolateral. And if I only remove, like here, let's see this diagram. If I only remove above the omohyoid, this is called supraomohyoid dissection, which is the MCQ, where I only remove 1, 2 and 3, supraomohyoid. So lateral is 2, 3, 4, posterolateral 2, 3, 4, 5, anterolateral 1, 2, 3, 4, 5, and radical all. And these are the incisions we give for neck dissection. And some of them they have already asked. One is Schrobinger, which is for anterolateral, like T, it's like T. Then you have Riley, which is for posterolateral, and then we have Whiteside, which is only for lateral. So 3 names: Schrobinger, Riley and Whiteside. And this is another incision, McPhee. Make 2 incision, lift the flap, do the surgery, put the flap back. This we prefer when we have to give radiotherapy post-operatively. So this incision image, I want you to remember, 2 incision, don't remove any part of the skin, lift the flap, do the surgery, put it back. Post-operative radiotherapy, this is best. And supraomohyoid, they have asked, supraomohyoid is this one, 1, 2, 3, above the omohyoid muscle. This is some points about radical neck dissection. And this is the image of Ranella. This also they ask. एक तो फोटो दिखा के पूछते हैं what is this, और एक वो पूछते हैं which nerve gets injured in Ranella surgery, lingual nerve. 2, 3 questions they do ask on this. Okay, false statement about salivary gland tumor is adenoid cystic has a tendency for perineural spread. Wharton tumor gives hotspot on technetium scan. Most common cancer of parotid is mucodermoid cancer. Arsenic cell tumor is most common in minor salivary gland. What is wrong? The wrong answer is 4. Arsenic cell tumor is a tumor of serous gland. And serous actually is parotid. Parotid is usually pure serous, submandibular is mucoserous, and minor salivary gland are purely mucinous. So arsenic cell tumor is seen in parotid and it's a low-grade cancer. Rest are true. Adenoid cystic is the most common tumor of minor salivary gland. And most common site is hard palate. तो आपको 2 पॉइंट याद रखना है. Minor salivary gland का सबसे common tumor है adenoid cystic. It has a tendency for perineural spread and it's most commonly found in hard palate. Wharton's tumor, adenolymphoma, gives hot scan. That's correct. Most common tumor of parotid is mixed parotid tumor, but the question says most common cancer. It doesn't say most common tumor, it says most common cancer. So most common cancer is mucodermoid. 4th is wrong. Arsenic cell tumor is not found in minor salivary gland, it's found in parotid. Okay? So in parotid, most common is pleomorphic adenoma, but most common cancer is mucodermoid cancer. Wharton tumor is second most common in parotid, 10% bilateral in males, common with smoking, and hotspot and scan, always benign, only seen in parotid. Adenoid cystic is low-grade cancer. Yeah, this is what I'm saying. Most common tumor of parotid is pleomorphic adenoma, but most common cancer is mucodermoid cancer. And arsenic cell tumor is a serous tumor coming from parotid. About sialolithiasis, duct stone. Submandibular stones are most common and they are radio-opaque, which is why they can be seen on X-ray and CT. For submandibular stone made up of calcium carbonate, which is MCQ, NCCT is investigation of choice. And for parotid, which are radiolucent, sialography is investigation of choice. But parotid stones are much rarer as compared to submandibular. Submandibular is the most common gland having stone. A 10-year-old boy presents with cystic swelling midline. The swelling was moving up with protrusion of tongue and swallowing. Which of the following is wrong statement about this condition? So can you answer this? Yeah. So this is a thyroglossal cyst. We can make a diagnosis, firstly age, boy, secondly moves up with deglutition and protrusion. Thyroid moves up with swallowing but not with protrusion. With protrusion, this is thyroglossal cyst. And follicular cancer is not high here. Papillary cancer may be found. So rest of the points are correct. And thyroglossal cyst, as you know, is the most common congenital anomaly in thyroid. It's a remnant of thyroglossal duct which disappears by 6 weeks. 5 to 20 years the usual presentation, common in female. Most common position subhyoid, moves with protrusion of tongue and deglutition, lined by pseudostratified columnar, may develop papillary cancer in 1%, treated by cyst trunk operation. In cyst trunk, you remove the cyst, complete tract and body of central part of hyoid. If I don't remove the complete tract, it will become thyroglossal fistula. So thyroglossal fistula is always acquired, not congenital. Either rupture of the abscess or incomplete removal causes thyroglossal fistula. And both, whether it's thyroglossal fistula or cyst, both are treated by cyst trunk operation. This is very important, and this is a question of last year NEET also. In few patients, the whole thyroid is present inside the cyst, and in those cases, if I remove the cyst, the whole thyroid is accidentally iatrogenically removed, patient will develop hypothyroid. So before we do thyroid surgery, thyroglossal cyst surgery, always order a scan, so that you know the exact position of thyroid. So the question last year was, patient has undergone thyroidectomy, child has undergone cyst removal, and then he becomes hypothyroid. What has happened here? The whole thyroid was inside the cyst, and unknowingly, the whole thyroid was removed. So this is very, very, patient will develop hypothyroid. So this is the image showing a cyst connected to foramen of cecum of the tongue. This is the surgery where the cyst is removed with the hyoid bone and the whole tract, and this is the site subhyoid, and this is the hood sign of you ask the patient, if there is a fistula, ask the patient to protrude the tongue. You get a concavity like this. This is called hood sign. So these are the salient points you need to remember about thyroglossal cyst. Very, very commonly asked question. So can you answer this question? So papillary cancer thyroid on iodine 123 scan will show hotspot. Vascular mets are more common. Multicentric. Cervical lymph node spread worsen the prognosis. What's wrong here? Oh, what's true? Sorry, not what's wrong. What's true? No. In papillary thyroid cancer, the worst prognostic indicator is age, not lymph node, and lymph node secondary does not worsen the prognosis in papillary cancer. The right answer is C. In 80%, it is multicentric. It will not give hotspot because they are not hyperfunctioning. Vascular spread is not common, nodal spread is common, and lymph node metastasis does not deteriorate the prognosis. So multicentric is main feature, and these are the points you need to know about papillary cancer. This is the most common cancer of thyroid, having the best prognosis, peak age 30 to 50 years. No, papillary is not unifocal. 80% papillary is multifocal. Female more common, prognosis mostly related to tumor size, and age is the most important, not node. Radiation exposure is factor, but remember, low dose radiation. This is very important. If I give high dose radiation like 6,000, 5,000 rats, the thyroid gets destroyed. So low dose, less than 2,000 rats. And the type is diffuse processing, which the type in radiation. Lymph node involvement more common than blood-borne, and lymph node involvement does not worsen the prognosis. Cure rate is high, small, and multicentric. More often it's multicentric. Nuclear membrane has a ground glass appearance called orphan NEI appearance. Mixed follicular and papillary is called as papillary, which is Lindsay tumor. If you have both features, then it's papillary. And occult papillary with lymph node lateral aberrant thyroid treatment is excellent. You don't have to do anything for that. And this is the orphan NEI nucleus and summer bodies. Both image they ask. They ask three histology. One is the amyloid stroma, which is medullary. One is orphan NEI nucleus, which is papillary. And third is summer body, which is again papillary. So summer bodies, which you also get in meningiomas and serous cystosoma of ovary and renal tumors and papillary thyroid cancer. So summer bodies and orphan NEI nucleus, these are features of papillary cancer. By using lateral aberrant thyroid is a occult papillary lymph node secondary. So this is a misnomer. Neither it is a aberrant nor it's thyroid. Yeah, BRAF mutation you get here, that's absolute. P53 and BRAF, that's correct. So lateral aberrant thyroid is a misnomer, which is a lymph node involvement of cervical lymph node with metastatic papillary cancer. So Z-plasty actually is to release contracture, make the tension less and gain some length. So if we take 60-60 degree, we get 75% length. See. So transposition flap examples are bilobe flap. This is a transposition flap. Another is rhomboid flap or Limburg flap. This is, so the angle we take is 120 degree and 60 degree, and all four limbs are equal in size. This is called transposition Limburg flap, and this is Z-plasty. To get length in, and the angle 30 degree gives 25% length gain, 45 degree 50%, 60 degree 75%, 75 degree 80%, 100%, and 90 degree 120%. The most commonly used angle is 60. This one. If I increase the angle, the tension is more at the suture line. A 41-year-old female with breast cancer undergoes biopsy where signet cells are seen. Which lesion is present? Signet cells you get in which? Yes. So Kirti is right, SS is also right. Neha, SK, Om Prajapati, Tanmay, Priyanka, Sonam, Srishti, you all are right. So this is found in lobular cancer. What are the features of lobular cancer? Number one, it's multifocal and multicentric. Unlike infiltrating ductal, it is multifocal more often. Number two, CDH, this is wrong, CHD नहीं होता, CDH होता, this is wrong. CDH1 mutation leads to E-cadherin deletion. Number three, more often ER/PR positive as compared to ductal, infraductal, mostly HER2 negative. Number four, histology shows single Indian file pattern. Number five, more older patient and low-grade tumor, better prognosis. And metastasis also some other side. The breast cancer goes to bone and liver and GIT, but it goes to brain. It's more likely to go to brain. Lobular has a propensity for brain secondary, which ductal does not have. So these are the features which are different in lobular from, and you get signet cell as well. So this is a single file pattern. Red Indian, they fight in one line, called single file pattern. So the cells are arranged in one line, called single file pattern, due to red Indian for Indian file pattern. A patient presented with acute right upper abdominal pain and fever for 2 days. Ultrasound shows West triad, LFT normal. What should be the next best advice for her? Can you answer this question? Yes. See, for a case of gallstone which presents with cholecystitis diagnosed by ultrasound, which may show West triad, treated by cholecystectomy, we don't order any other incision. But when the stone goes in CBD, And how do we get the hint? How do we get the doubt? Number one, ultrasound showing dilated CBD more than 8 millimeter or LFT showing obstructive jaundice in which alkaline phosphatase will be high, direct bilirubin high, then we order MRCP. So you can see LFT is normal, ultrasound only showing West triad, not showing dilated CBD. So the answer is only elective laparoscopic cholecystectomy. If in this question, if the CBD was dilated more than 8 millimeter or LFT showing obstructive jaundice or alkaline phosphatase high, then we would have ordered MRCP. So this is the gallstone, which gives a echogenic shadow and the acoustic shadow behind it. This is a polyp where we don't have acoustic shadow. This is how you differentiate gallstone with polyp. And any polyp more than 10 millimeter should be removed for the risk of cancer. Less than 10 millimeter, we order conservative observation. And this is the West triad where we can see the wall, echogenic shadow and acoustic shadow suggesting chronic cholecystitis. So if the CBD is dilated or ultrasound showing LFT showing high ALP direct bilirubin, then we should order MRCP. Without MRCP, we should not operate. And this is a normal MRCP. MRCP is T2 weighted MRI. We don't use any dye in MRCP. Bile itself acts like a dye. And this is a condition where we have gallstone and CBD stone. Here my treatment will be first ERCP for CBD stone followed by laparoscopic cholecystectomy. So I'll just verbally tell you quickly. Whenever a patient comes with right upper abdominal pain, we order ultrasound and LFT. Ultrasound shows only gallstone, LFT normal, we don't order anything else. We order cholecystectomy. But if ultrasound showing dilated CBD or LFT showing obstructive jaundice like alkaline phosphatase high, direct bilirubin high, then we simply go for MRCP. And if we find stone in the CBD, first treat CBD stone by ERCP, then cholecystectomy. West triad has no significance except that this is a sign of chronic cholecystitis. So when there is a West triad, we know it's a cholecystitis, and CBD normal, we'll order cholecystectomy. So I guess you have understood this part, that if simple gallstone is there, we just order cholecystectomy. If CBD stone is there along with gallstone, then we order ERCP followed by cholecystectomy. But how do you diagnose CBD stone? By MRCP. And how you suspect CBD stone? By dilated CBD on ultrasound or obstructive jaundice. So is it okay? And CBD stone can present with cholangitis, which is called Charcot's triad, fever, jaundice and pain, can progress to septicemic shock. So now with fever, jaundice and pain, we have altered sensorium shock, and both of these conditions, immediately ERCP should be done and drain the CBD, which we call as decompression. So ERCP and decompression of CBD. So this is an emergency patient with die of septicemia, ERCP and decompression of CBD by ERCP. If gallstone is an incidental finding without abnormal LFT, then also we should know. If the gallstone is less than 3 centimeter and it is asymptomatic, then it is kept under observation. There are certain indications of cholecystectomy in asymptomatic stone, in asymptomatic gallbladder. Stone is one of them, but the size should be more than 3 centimeter. Less than 3 centimeter, we keep under observation. Yeah. So, a 35-year-old female presents with abdominal pain and jaundice. Size for asymptomatic gallstone is 3 centimeter. So, cystic anomaly of bile duct. This image itself, they gave an exam and asked what it is, and they asked question based on this. So, I'm sure all of you can diagnose this condition. What is the diagnosis here? The diagnosis is choledochal cyst. Choledochal cyst. Type 1, which is most common type, 80%. If I drain this cyst into the duodenum or jejunum in the hope of facilitating drainage, then the risk of cholangitis is very high, plus cancer risk is also there. So, we don't do this, we only do this. Remove the cyst and do Roux-en-Y hepaticojejunostomy. So, this is the Tewari classification. Type 1 is more than 80%. This is what's shown in the image. You excise and do Roux-en-Y hepaticojejunostomy. Type 2 is a divert clump. Type 3 corticocele. Type 4A intra and extrahepatic cyst. Type 4B only extrahepatic. Type 5 only intrahepatic. Yeah, cholecystectomy is also done here because of the cancer risk. So, you cut the whole thing, go to common hepatic and do Roux-en-Y hepaticojejunostomy. Okay, like here. Although this is a Roux-en-Y anastomosis is done with CBT, but no, we do from common hepatic hepaticojejunostomy, Roux-en-Y. A 70-year-old alcoholic presents with tender upper abdominal mass. Carolese is type 5. Type 5 is Carolese. The lump is persisting for last 6 weeks. CT shows a thick wall, 2 cm wall thickness, round fluid filled 6 cm mass adjacent to pancreas. Can you tell me the diagnosis here? 6 weeks after trauma, see the CT scan. There is a cystic swelling anterior to pancreas. What is this? Yes, this is pseudopancreatic cyst. Because the duration is more than 6 weeks and the size also is 6 cm, we should drain it, and the best treatment is cystogastrostomy, drain in the stomach. This is a pseudopancreatic cyst in the lesser sac, more than 6 cm size, more than 6 weeks, and wall thickness is wall has already matured. We should go for cystogastrostomy. So, this is a pseudopancreatic cyst. So, why not C? Yeah. So, for pseudocyst, you do cystogastrostomy, but before 4 weeks, the wall has not formed and it's not called pseudocyst. Pseudocyst is only called when it is a fibrous wall, and fibrous wall develops after 4 weeks. So, before 4 weeks, if the cyst gets infected, then we should go for percutaneous drainage. So, I'll repeat. Percutaneous drainage is not the treatment of pancreatic pseudocyst. It's a treatment of peripancreatic fluid collection which gets infected. So, before 4 weeks, I can do this. Less than 5 cm are less likely to have complication. So, we can keep under observation. No, after 4 weeks, we don't go for surgery. After 4 weeks, it becomes pseudocyst. The wall becomes mature after 6 weeks. So, we go for surgery after 6 weeks. Okay, not after 4 weeks. So, I guess you have understood this point. Any confusion here? You see, Aderin, D. Angelio. Okay, you see, when there is a fluid collection, we call it peripancreatic fluid collection, and they develop fibrous wall, then we call it pseudocyst. When we have necrotizing pancreatitis and leave for 4 weeks, it develops fibrous wall. That's called walled-off necrosis. So, the difference in pancreatic pseudocyst and walled-off necrosis is just one. They both develop after 4 weeks. Pseudocyst develop after fluid collection, and walled-off necrosis develops in necrosis. So, walled-off necrosis also is usually infected. That also needs the drainage. Pseudocyst also is likely to develop complication. So, we operate after 6 weeks after the wall becomes mature. Yeah, less than 4 weeks, peripancreatic fluid collection is managed conservatively, and most of them gets absorbed. If they don't get absorbed, then there are two probabilities. Either they get infected, we do percutaneous drainage, or they are there for more than 4 weeks and then they become pseudocyst. So, don't do anything for fluid collection before 4 weeks. If in case it gets infected, go for drainage, percutaneous. After 4 weeks, they become pseudocyst. If they are more than 5 cm, more than 6 weeks old, do cystogastrostomy. Okay? Have you understood this point? Okay. A 25-year-old male, this is a question of INICT. The infection comes from GIT bacteria. GIT bacteria can cross the wall of bowel transmural without perforation. So, if I keep the patient nail only for very long, the mucosa become atrophic and the bacteria, only GIT bacteria goes to necro tissue without perforation. So, source is GIT only. Pseudocysts you can manage conservatively when they are very small and like less than 5 centimeter and no complication. Otherwise, you should go for cyst. So, fever is 1, nausea is 1, tenderness is 2, WBC is again 2. So, 4 and 2, 6. What is? Yeah, radiating pain 1. So, answer is 7. So, this is menstrual, migratory pain, anorexia, nausea, vomiting. The only difference in this question, INICT question, here I have written tenderness and the question was rebound tenderness. Rebound tenderness was only 1. So, there the answer was 6. So, this Branchial, I guess all of you know, you have to memorize this. They do ask this very often. A neonate is born with abdominal lump. Ultrasound showed left kidney with severe hydronephrosis and severely distended pelvis. Ureter is not visualized. Renal scan showed isotope draining from right kidney within 15 minutes, but in left kidney isotope was retained for 2 hours. A diagnosis of left PG obstruction was made with 10% renal function. He is a neonate. What should be the ideal treatment? Okay. So, here we could have gone for pyeloplasty, but there is one issue. The issue is poor renal function. So, if I do pyeloplasty and function does not recover, then in future I will be doing an nephrectomy. So, which is why first, like this is the kidney, this is the pelvis and obstruction here. So, what we do, we put a tube here and leave it, percutaneous nephrostomy. Bypass the urine and relieve the obstruction. When we do percutaneous nephrostomy, the back pressure gone, kidney gets rest, and now you wait for 4 weeks and get a repeat scan done. If the function improves, go for pyeloplasty. If the function is still very poor, like 5%, 6%, you can do nephrectomy. So, in neonate, the regeneration potential, had it been an adult, then in 10% function, I would have gone for nephrectomy. But in neonate, the regeneration potential is very high. So, we don't do nephrectomy, we go for PCN, so that we give a chance for the kidney to regenerate and then we operate. Have you understood this? So, like here, so this is a PUG obstruction here. In VUR, the whole ureter will be visualized, which is why it's not VUR, like here. This is the clubbing on ultrasound, minor calyx clubbing in pelvis and no ureter. While here with kidney, I can see the ureter also dilated. So, second is VUR, while vesicular reflux, my first is PUG. So, this is a scan where you can see this kidney has drained and this is stuck, the isotope is there, even 1.5 hour. And which scan? MAG3 is best. If not, then we can go for DTPA. And this is Anderson-Hines pyeloplasty, dismembered pyeloplasty, most commonly done pyeloplasty for PUG obstruction. So, always we do pyeloplasty for PUG obstruction, but if the kidney function is very poor, we do nephrectomy. And if the kidney function is borderline, especially in children, always do PCN, give a chance to kidney to regenerate or to survive, and then you go for second stage nephrectomy. A 42-year-old female presents with bilateral flank pain and occasional dysuria. X-ray images given below. What type of crystal you expect in the urine? Yeah, DMSA is to know the structure, anatomy, and DTPA is to know the physiology. Yes, I will tell you about pyeloplasty malady, just give me some time. First, let's understand this. Let me finish this, then I'll tell you pyeloplasty. Yes, this is a struvite stone, which is a magnesium ammonium phosphate. So, this is a phosphate stone. This is Staghorn calculus, and here we get coffin lid appearance. So, oxalate gives envelope shape appearance, triple phosphate, coffin lid, and cysteine hexagonal. This is found in acidic urine, this is found in alkaline urine, and oxalate can be found at any pH, acid or alkaline. So, alkaline has triple phosphate because of urease or protease. So, infection, and that infection breaks the urea, makes the urine alkaline. So, here, and this is the Staghorn calculus, which has triple phosphate composition. So, in alkaline urine, so see, this is envelope shape, the first one, calcium oxalate, cysteine hexagonal, coffin lid, triple phosphate, which is Staghorn. This is the Staghorn, the X-ray we showed. And what is the treatment for Staghorn? Another question, PCNL. And this is rhomboid or needle shape, that's uric acid. Rhomboid or needle shape uric acid. This is protease infection, triple phosphate, coffin lid. And this is the Staghorn calculus. False statement about TEP repair is. So, can you answer this question? Probably little difficult for some of you. Any stone more than 2 cm should be treated by PCNL, and because they are always more than 2 cm, PCNL is the best treatment. So, what's the answer of this? Yes. The wrong statement is A, and the reason is we do not create pneumoperitoneum, we remain outside the peritoneum. It is totally extraperitoneal. So, we put a Wiere's needle inside, insufflate CO2, this is TAP, transabdominal. And here we remain outside the peritoneum, TEP, so we don't have to create pneumoperitoneum. So, A is wrong. Okay. So, one question is, what's the difference in monohydrate and dihydrate? See, calcium monohydrate is very rare and they are very hard, not broken by ESWL, and they are bipyramidal or dumbbell shaped. Dihydrate is the main type and they are envelope shaped. Okay. So, normally at the end I show you some X-rays and IVPs and CT. Today I'll show you some instruments. So, this is a closed suction drain called Romovac. All these have been asked. Cysteine is also hard. Yes, cysteine is hard. And this is Jackson Pratt drain. Both are closed suction drain and both are commonly asked. No, intubation is not done in chest NG. Tension means you put needle. This is pneumatic compression device to prevent DVT post-operatively. This also they have asked in question. Number 3, this is Humbee's knife for skin grafting. Which is skin grafting? Split thickness. Split thickness is skin grafting. Again AMCQ. Now this is Jaws thyroid retractor. We use 2 Jaws thyroid, one on this side, one on this side, to expose the area. Okay. And this is right angle forceps called mixture. This is an AIMS question. Like I want to ligate a duct, cystic duct. So I pass the right angle below the cystic duct and opens. My stent will feed the thread. I catch hold the thread, pull it, and then I ligate. So for deep vessel ligation, deep duct ligation, right angle is used called mixture. These are 2 vascular clamps. First is Bulldog and second is Setinsky, like venal pedicle and all those. This is Wiere's needle, which they do ask very often. The valve is here to prevent CO2 leak. The tip is blunt, like here, and when you push, the blunt part goes in, the sharp part comes out, and then when it goes in, again the blunt part comes out, avoiding the bowel injury. It is spring loaded and you can hear the click when it goes in. Wiere's needle also very often they ask. This is Wiere's. These are the cannula, 10 millimeter cannula. This is normal, this is Harson's. In Harson's, you'll find this triangle here. So whenever you have a shoulder leg thing, this is Harson's. The Harson is used for open technique and this is used for closed technique. This is phanestrator retractor for thyroid, for thoracic surgery, retraction of the rib, thoracotomies. This is central line. Yeah, these are PYQ. Most of them are PYQ. Yeah, angle was asked last year only. So laparoscopic angle, azimuth, elevation, and manipulation you have to remember. So these are the CVP line. You can see 3 ends here going like this. It should be placed in superior vena cava. Pneumothorax is the common complication they do ask. This is Fogarty caster for embolectomy. At the end of this, you'll find a balloon here. So put the caster through the thrombus or embolus, inflate the balloon and pull it out. It will remove the balloon along with it. No, CVP line subclavian is best, but we put it through jugular vein. So jugular is used more often. Azimuth is not 30 degree. Azimuth is 30 degree. Manipulation and elevation is 60 degree. Yeah, if only one artery you have to choose, then go for superior epigastric artery. This is Fogarty. These are 3 staplers, linear, only used for side-to-side anastomosis, cut and staples. This is laparoscopic linear stapler. This is circular stapler, used for end-to-end anastomosis and end-to-side. And this is TA stapler. Only it will seal, it will not cut. It will only seal, staple without cutting. These two they cut, it doesn't cut, only staples. Chemo port, this also has been a patient requiring regular chemotherapy. We put a chemo port here, connected to subclavian here, and you can inject the chemotherapy directly into this chemo port. This also they have asked. And this is the PEG tube, percutaneous endoscopic gastrostomy tube. You can directly put it in the stomach and feed it through this. PEG tube also they have asked. True cut biopsy forceps. The edge is sharp and it goes in and it will take a specimen here. No, subclavian is best. Most commonly used is internal jugular vein. This is spring-loaded true cut biopsy. Both are true cut biopsy. This is a bone marrow biopsy needle. This is also they have asked. And finally, this is message for you. Subclavian is always better. So you can very well use subclavian, but yeah, bone marrow biopsy Jensen. So these are some instances. Now you can ask questions. I can recall some questions. One of you wrote MRCP versus ERCP. Anshita, ERCP today is not a investigation for diagnosis. ERCP is only and only for therapeutic purpose. ERCP is invasive, so we don't order ERCP. Whenever they ask what is the IUC for cortical cyst, what is the IUC for stricture, what is the IUC for CBD stone, only one answer, MRCP. So that's one question, one problem. Pyeloplasty. Okay, I'll show the pyeloplasty as well. TEP and TAP. I'll draw a diagram. Let me give me some time. You give me some time and I'll, just 1 minute. So, TEP and TAP. देखो, just 1 minute and you'll understand. देखो, ये skin है, ये rectus muscle है, and this is the anterectus sheath, this is posterior, and this is peritoneum. So, if I go into the abdominal cavity and do repair outside peritoneum, this is called TAP, trans-abdominal pre-peritoneal, through the abdomen pre-peritoneal. And if I go in and remain outside peritoneum and repair, this is called TEP, totally extra peritoneal. So, name itself tells you, TAP is trans-abdominal pre-peritoneal and TEP is totally extra-peritoneal. So, the question is TEP. So, I don't have to put CO2 in the abdomen because I am not going in the abdomen. We remain outside the peritoneum. So, I guess you have understood this. Trans-abdominal pre-peritoneal and totally extra-peritoneal. Number 2, this term, onlay, inlay. This is the rectus, this is the anterector sheath, this is posterior, and this is peritoneum. If I put a mesh here outside the rectus, we call it onlay. If we put in between, like linea alba, we call it inlay. If I put it behind the rectus, we call it sublay. And if I put it inside the peritoneal cavity here, we call it IPOM, intraperitoneal onlay mesh. So just like onlay, this is also onlay, but it's inside, intraperitoneal, inside the peritoneal cavity, which we don't prefer because now it is in contact with the bowel. No, we use CO2, Manoj, but we use CO2 in the pre-peritoneal space, not in the abdominal cavity. We don't have to put the various in the abdominal cavity. We open, put Hassan cannula and remains for the study in front of peritoneum. Overlay and onlay are same, but sublay and underlay differs. Sublay is behind the rectus, anterior to muscle, and underlay is behind the posterior sheath. Overlay and onlay are same. Yeah, Pusto and Becher, the photo you have to understand. They do ask photos. And urethral injury, if you suspect, you should always go for retrograde urethral. If you suspect. Underlay is behind the rectus muscle. This is the sublay. Let me explain it again. Let's say the red line is the posterior sheath, red line. So if I put the mesh here behind the rectus muscle and anterior to rectus sheath, I call it sublay. And if I put the mesh here below the rectus sheath, I call it underlay. But sublay and underlay you can consider same. Don't worry about it. Cannula is the sheath. This is the cannula. Inside I will put a trocar. What goes inside is called trocar, which I'll remove after inserting the cannula. So trocar is the inner instrument which along with cannula is only used to introduce. Then you take the trocar out and the hollow sheath is called cannula. In Wilms tumor, you should remember classification if you can, but European classification normally we don't advise, they don't even ask. Treatment, of course, you have to know. IPOM is not on the organ, it's inside the peritoneal cavity, it's on the peritoneal surface. So I think I'll stop now. I can show you the photos also, Bejer and Pusto, but I think you'll find it in the book also, so you can very well. Yeah, dekho Neha, MAG3 is the safest scan in children, which is why we prefer MAG3. If for physiology, but if MAG3 is not possible, then we go for DTPA. DMSA we order for to see the anatomy, not to see the function, to see the structure. So DMSA we don't order for PUJ obstruction. Hassan is used for open and Viris Needle is used for close. No, Wilms we don't have any Indian classification. Yeah, omentum visible. Now it all depends where you are working. If you don't have CT scan emergency, best is to do laparotomy. But if you have CT scan, you can keep under observation. When patient deteriorates, get immediate CT done. Fast is not a good treatment for investigation for omentum. Because historically, conventionally, evisceration of anything you should do laparotomy. But this is an old concept. Now patient is stable, you have CT scan, you can keep under observation. In case he deteriorates, get a CT done. Spinoplasty, I will show you, see here. these are different types of pyeloplasty, most commonly done in Anderson-Hines. And dismembered, you cut separate. Just cut this area which is diseased and do pyeloplasty. If you don't cut and separate, then we call it non-dismembered, which has a vertical flap, spiral flap, or even YV-plasty. Basically, the purpose is to make this area wide. So you can have different type of plasty. Only remember one which is given in your book, Anderson-Hines pyeloplasty, which is for PUG obstruction, dismembered pyeloplasty. WIMS tumor management is surgery and chemotherapy. Stage 3 onward, radio is also added. National WIMS tumor staging group. Do nephrectomy first. Depending on the stage, add chemo. Usually actinomycin D and vincristine. Rarely we add adriamycin. So stage 1 and 2 only surgery, or stage 1 favorable only surgery, 2 chemo, and 3 onward radio is added. Okay, so yeah, Anderson is dismembered. All other are non-dismembered, not given in your book, so not included. Definitive surgery is not included in damage control, that we do in the stage 3. Okay, so I'll stop now, and my sincere advice to all of you, do revision and do MCQ. Don't read anything new, just do revision and do MCQ. So all the best to all of you. Thank you. RCC is not only based on size, this is called renal nephrometry score. Renal R is radius, interior, posterior, how near it is to pelvis and central. So you see many criteria. Okay. So all the best to all of you. Thank you. Stage 1 is the damage control surgery, abbreviated laparotomy. Stage 0 is resuscitation. Stage 2 ICU. Stage 3 definitive surgery. Okay, so I am going to stop the stream now. I don't see any new question. Yes, less than 4 centimeter you can do partial nephrectomy, but in some cases up to 7 centimeter you can do partial nephrectomy. So up to 4 it's a definite indication, up to 7 it's a relative indication. One can do partial nephrectomy. Okay? Right. So good night and all the best. No, Fuhrman is not important, but remember what parameters are included. Fuhrman and Leibovich, both for RCC, remember what parameters are included. Just parameters like nuclear